So, as I said, we're going to talk about menopause today, and I'm very conscious that I'm talking to a lot of very expert MSK people, so I'm not going to bore you with osteoporosis and that side of things so much, but we will talk a little bit about MSK kind of issues towards the end. But I'm going to talk a little bit more about what menopause is and how it looks. So menopause is a retrospective diagnosis. So you get a lovely menopause day, basically, where you've had 12 months of no periods if you're over 50 or 2 years if you're under 50. And, I think you should get a big cake or something on that day because all of a sudden, that's it. That's menopause. But as you can see, and the reason that I kind of put this woman's life up in hormones, this is one that I show patients a lot because I think it kind of nicely explains why we don't do an awful lot of blood tests and things in menopause now, because that menopause day is just one little aspect of it. You can be perimenopause for so long beforehand where everything is going a little bit haywire. And I think you can see on this little graph that actually once they're down here, your hormones we're already kind of really low and fairly steady. But in this perimenopause stage, it's chaos. And that's why those blood tests aren't terribly useful because we could be highlighting that they're really high, but they might be really low the next day. It doesn't mean that you're not perimenopausal, just means that you've not gone through menopause yet. But that's where you're going to get that fluctuation is often where you're going to get most of the menopause symptoms and those hot flushes, the night sweats, and all these kind of symptoms that we're going to talk about. So menopause kind of usually occurs somewhere between kind of late 40s, mid 40s to mid 50s. Most women by 55 have gone through menopause. But you can, as I say, you can be perimenopausal for quite some time beforehand. So what does it actually look like? So this is a picture that I've always put up as, it's a little bit of a comedy picture of how you're coping with hot flushes. But it does worry me a little bit that this is how we view menopause, that we talk about, we focus so much on the hot flushes and that, people with a fan and cooling down. But actually we're kind of trivializing it and making it quite comedic, which I'm guilty of myself in lots of my talks. But we don't want to trivialize it. We don't want it just to be about how to cope with those hot flushes. So, I mean, I'm hopeful. Jennifer Aniston, I believe, is 55 now. I'm very much looking forward to being 55 and this being me. But for most women, menopause looks very different. And the symptoms aren't just those traditional hot flushes. They give us a good indication, but there's lots there that I'm sure you've kind of come across: the brain fog, the night sweats, the sore breasts, the irregular periods, vaginal dryness that we don't really talk about and think about enough, and that kind of effect that can have on your libido, on your urinary side of things, mood swings, but also lots of things that you might not think about: dry eyes, vertigo, tinnitus type hearing changes, burning mouth syndrome. So not only are you putting on weight, are you having all these kind of issues that are affecting how you view yourself, but now you're also getting things that taste different, that smell different, that your body odor has changed, your skin is itchy and dry, maybe you're getting maybe cold flushes alongside those hot flushes, and then heart palpitations. It's a really very kind of different picture to just some hot flushes that maybe a fan and you can cope with. So these are all ones from different websites that I found with different symptoms, but actually you could go on for absolutely hundreds of different symptoms and things that we often do just kind of dismiss and don't put together as being menopause based. So some of the things that to kind of think about as well. So menopause isn't just about all the symptoms. There's a lot of other things that come with that, conditions that come with that, like the osteoporosis risks and the post-menopause, the cancer risks with some of the treatments, the general aging side of things as well, and how you're coping with that with menopause. But also some of the views around that about how we often will stigmatize menopause, often, I hear lots of people say, oh, but my friend has just sailed through, or my mom just sailed through, and you don't need, it's not an illness, it's just a stage of life. Yeah, but it can be a fairly awful stage of life for lots of people. So only around half of women who go through menopause do so consulting a medical professional. So there's a huge proportion that we don't even see that are probably struggling with it, because 77% of women find at least one menopause symptom really difficult, and it interferes with their quality of life. And 10% of women actually leave their jobs due to menopause and due to symptoms. So thinking about menopause symptoms and about women who are going through menopause is, and I should kind of say, I do use the word woman quite a lot, but obviously there are other kind of phrases that we should be used now, and I apologise, but I do tend to still say women most of the time. But only 14% of women are on HRT, and as I say, 10% leave their jobs due to menopause, which I think is a horrendous statistic. That you're leaving something that potentially you love, something that can have a massive impact on your lifestyle and your household income due to menopause symptoms. So we can't really talk about menopause without talking about HRT. And as it was kind of alluded to just before I started, that there was the Panorama program recently with Louise Newson, who's a big advocate for menopause treatment and for HRT. We do have to think about the kind of context of some of that. She's quite an outspoken female advocate, and I think that even if some of her treatments have been off-label and have been something that we need to think about and look into more, the guidelines are changing a lot over the last few years. So if you put it into context, some of the things that she's been doing we didn't have guidelines that addressed those issues at that stage. So yeah, I think it bears more investigation really, but at least she is a really good advocate for HRT and for actually talking about menopause. We've learned now that the risk with HRT varies with the route and type, so I'm not going to go too much into HRT, but basically we have different types that we can use now. We have oral, which used to be, everyone used to have a tablet basically, with if your uterus is intact, with estrogen and progesterone in, and that was the one tablet. That was what you could have basically, was a HRT with both of those in of some sort. But we've learned that actually there are risks associated to that. There's a slight increased risk in breast cancers and a slight increased risk in blood clots. And actually, if you have other risk factors, which a lot of menopausal women do have for blood clots, that was putting that risk up considerably. But we've learned that actually, that if you have transdermal, so if you have estrogen that goes through the skin, and some of the newer types of progesterone, so something called micronized progesterone, which is a body identical, which I always say this sentence to patients, it's as close to what we make as we can make in the labs, if that kind of makes any kind of sense. So it's body identical. So you get less side effect profiles, you get kind of better tolerance, and it is just as close to what we make naturally as we can make. I believe it's made from yams, and I always get a bit confused because I think yams are just sweet potatoes, but that seems like a massive jump for some reason for me. So, but apparently that's what it's made of. So you can individualize it, and we know that if we have that kind of regime, it's breast neutral if you have that for 5 to 10 years, and there's no increased risk of blood clots. So there's lots of things now that we can tweak with that regime that reduces those risks, and things like the Mirena coil that can really help with endometrial risks. But what I do find is that we're not always just talking about the actual risks, but we're talking about the patient's beliefs and anxieties and their perception of those risks. And that can be just as hard sometimes as looking at their actual risks. We have patients who have got strong family histories of breast cancers and things like that. They might feel that their risk is just too much, even if we were explaining it that actually these are breast neutral. So it is about really individualizing things. These are the main risks that we talk about: breast cancer risks, VTE risks, and endometrial cancer risks. But the side effects that can as well. I mean, we do have to remember that this is the getting on top of their menopause symptoms has to be worth taking something every day. And if you're getting really bad side effects with that something that you're taking, then actually it depends how severe your menopause, how much your menopause symptoms are affecting you. For some people, we might think their menopause symptoms are fairly mild, but actually taking something every day is fine. They don't have any side effects and they're really happy to do that. For other people, they might have really severe menopause symptoms, but actually it's just not worth the side effects that they, or the risks that they perceive. So some of the risks, some of the side effects that we have a bit of breast tenderness, gastrointestinal symptoms. There's lots of things like bloating, nausea, headaches. The micronized progesterone can help with sleep, so it can be a little bit sedatory. So sometimes it's about getting them to take it at the right time of day. So taking that at night helps with their sleep side of things, as opposed to taking it in the day where they're just going to be drowsy. And there are lots of supplements. Now, I'm always a little bit cautious of talking through supplements with patients. I kind of highlight them and I send them off to do their own research on them, because I'm not an expert on homeopathic and supplements. But there are a few things that are a bit of a no-brainer. Vitamin D, and a good multivitamin with vitamin D is fantastic. Evening primrose oil is really great for breast tenderness. Skin side of things, itchy, dry skins, any moisturizers with vitamin E in are really good. And then there are some that I kind of tell them they need to be cautious with, and especially if they're taking HRT, they really need to avoid. And those are the ones that kind of mimic estrogen, like black cohosh, and soya, and some of those ones that actually they're either going to be competing for the same things, or we're giving them, they'll potentially give them just as much risk, but without so much benefit from an unregulated, untested kind of source. So there are some that I do kind of advise them to avoid. And patients will come to you, they'll have tried all sorts of random supplements. And in fact, one of my nurses was trying some green powder supplements that they bought off some dubious website, that because they definitely helped with menopause. And actually, when you looked at it, all it was B12 basically, and some multivitamins. So you can go for very expensive kind of patches and powders and things, but really a good multivitamin is a good start. So we talk a lot about risks, and the one on the left is a really common infographic that I'm sure lots of you have seen, that kind of contextualize that breast cancer risk. So there are, as I say, there are some breast neutral choices, but if you actually need something that has a progesterone in, a synthetic progesterone, where you have that little bit of increased risk of breast cancer, you do have to put it into context that there can be an additional 4 cases in women on combined hormone replacement therapy, but actually there are 7 fewer cases in women who take at least 2.5 hours of exercise a week. Being obese, we don't talk about your increased risk of cancers being obese, but it massively increases your risk for endometrial cancer and for breast cancers. And yet we don't really talk so much about that. Obviously, smoking, we kind of know that. Get an additional 5 cases in women who drink 2 or more units of alcohol per day. So there's lots of things that we can do, we can encourage to do to reduce that risk. And there are, as I say, breast neutral versions now. I think this other side, the Primary Care Women's Health Forum, if you haven't come across that, it's a fantastic forum and a great website with loads of resources. It's really worth joining if you've got an interest in menopause, or you're coming up to menopause, or anyone that you know is coming up to menopause and you feel you need a bit more information. And one of the things that highlights is that no extra women have died from breast cancer related to their use of HRT. I think that's a big thing, that often with breast cancers in HRT, we now get you your HRT reviews to make sure you have your mammograms, to make sure you're checking your breasts. We talk to you about what breast cancer looks like and what it feels like and what kind of things you should be doing. That actually, if you do get breast cancers, it tends to be found earlier. So we also don't really talk about this side of things, that more women die of dementia than breast cancer, and of respiratory disease, and twice as many die of heart disease than breast cancer. So sometimes we worry about risks that are minimal, and we kind of ignore the ones that are there as well. And this very much kind of shows that, you know, we talk about risks of HRT, but we don't talk about risks of menopause. And Diabetes UK kind of look at the fluctuating blood sugars and your health risks with that, from just how that natural changes in estrogen and progesterone change how your cells respond to insulin and change what your cells are doing. Low estrogen is linked to an increase in cholesterol levels, which obviously increases your risk of heart and circulatory disease. So again, something that we can improve with the HRT side of things, and those benefits to taking HRT. The osteoporosis side of things that we'll talk about a little bit later. And some of the kind of chronic diseases that have been linked with menopause, such as rheumatoid arthritis, chronic fatigue syndrome, and that early menopause risks as well, that again, the HRT side of things could be helpful. So it's not all about the HRT. And, you know, I could talk to you for hours on HRT and the different types and what you can use and what options there are. But actually, there's also an awful lot of other things that we should be doing. Now, a lot of time people will say that these are alternatives to HRT, but I don't really like that. I think they are complementary to HRT or adjuncts to HRT, that actually we shouldn't just be handing out a prescription. We should be talking about the lifestyle modifications and those kind of things that can make a big difference. So some of the things I talk about a lot with my patients, kind of hot flushes and night sweats, regular exercise, weight management, which is never an easy conversation when you're menopausal and you're struggling to lose weight and your body shape has changed and you've probably already reduced your portion sizes and increased your exercise, but perhaps not enough, because now you're having to do more to get any kind of maintenance or effect. Kind of wearing lighter clothing, sleeping in cooler rooms, a lot of things like this patients have already done. But looking at stress reduction and CBT can be very helpful from that side of things, and avoiding triggers like spicy food, caffeine, smoking, alcohol. Sleep disturbances is a massive thing in menopause. And again, there's some HRT benefits with the micronized progesterone, but there's also things that we can do ourselves, looking at our sleep hygiene, avoiding exercise late in the day, maintaining a regular bedtime and that routine, cutting down on the blue screens, you know, reading, all those things that we do when we've got kids, when you've got toddlers, that you do automatically and that you do to make sure that they're going to bed and they're getting to sleep. As adults, we forget that and we're rubbish. We sit watching TV until way too late. We sit on our phones in bed and have TVs in our bedroom and all these things that are really bad for our sleep and our sleep hygiene. That if you did that, if you put on TikTok that was your toddler's room, that you were, you know, letting them play on their phone late at night, and that they'd got a massive TV in their room and that TV was on while they were playing on their phone, and you'd get slated on TikTok, wouldn't you, for that sleep hygiene for kids. But we just forget about that as adults, and life kind of gets in the way. So taking a step back to all of that, looking at the mood and anxiety side of things, again, sleep and exercise is so important. But looking at relaxation exercises and again, for the cognitive symptoms, an awful lot of this is quite repetitive. But I would say that you have to really individualize this. And so this is my perfect example. This is my hot friend Jodie. She's consented to have her she was thrilled, in fact, to have her screen grab up on this presentation. So my friend Jode is the same age as me, depressingly, and she decided when we were coming up to 40 that she was going to get fit for 40, and she's smashed it out of the park. And we're now 44. And she started having some menopause kind of symptoms, some hot flushes and just nothing major, but just quite mild menopause symptoms. And because she knows me and because I'm always going on about things like this, she went to see a GP. She went dressed pretty much like this. I think it was a neon pink version, because to be honest, this is pretty much how she dresses all the time, because why wouldn't you? So she went pretty much like this, straight from the gym. And her GP told her that she needed to look at her diet and her exercise regime. And so she showed him her attempt to be a gym influencer on Instagram. And he said, yes, yeah, you need to look and do probably more cardio. Well, the last thing she needs to do is more cardio. Her gym work is pretty perfect. She does a lot of weight bearing exercises. She does her cardio as well. She does park runs for fun and 10Ks without blinking. Her diet, she has protein muffins as a treat. It's pretty perfect. But they really missed by focusing on that lifestyle on the wrong thing, and by just giving her a general leaflet that this doc had got printed out about diet and exercise. They missed out on lots of a real wasted opportunity. Now, I think she probably could do with a little bit of HRT. And I think particularly one of her particular problems is anxiety, something she's always struggled with, but which menopause is just making worse. So actually some CBT, talking about relaxation, talking about gratitude journaling, things like that that are focused on her anxiety would have been much, much more of a useful time. She's also terrible sleep pattern wise, and she does do the classic falling asleep on TikTok. And again, talking to her about her sleep hygiene and about her routine side of things would have been much more beneficial. She goes from home working to the gym to home working. So again, talking to her about getting out in nature, about how she varies that routine up would have been much more useful from her anxiety and mental health point of view. So it's a shame they focused in on the lifestyle options, but they didn't individualize it, and missed a massive opportunity actually for a really good kind of coaching session. So that appointment was just a waste of time. She didn't have any HRT, and she didn't have any kind of useful lifestyle advice. So it is all about it being individual. So this is what NICE kind of say, is that we should adopt an individual approach at all stages of diagnosis, investigation, and management. And explaining the stages of menopause. Lots of patients come into me wanting a blood test to show that they're menopausal. And actually, as we saw in the earlier slides, that blood test might not show that, but it doesn't mean that they're not perimenopausal. And it's acknowledging that, and it's explaining that we work through it on their symptoms, and it's a diagnosis based on their symptoms. Yeah, we might want to do a blood test to make sure we're not missing anything else. And if they're particularly young, if they're under 40, then yeah, we definitely want to look into it a little bit more and see what's happening. We don't want to diagnose someone as menopause just because they've got a couple of symptoms that could be menopause. But we also don't want to delay that diagnosis until we can get a blood test or a test that proves it. Talking about the long-term health implications, talking about the kind of symptoms they can expect. And sometimes it's teasing those symptoms out. Lack of libido and vaginal dryness are things that people rarely mention until you ask them. They'll come in and talk about hot flushes and about mood and about mental health and anxiety. Sometimes that can need a little bit of teasing, but quite often the vaginal dryness will only come out if you do a smear or if you directly ask them. And giving lots of information about HRT, reassuring them, talking about their concerns with it, not just generalized risks. There is a place for non-hormonal side of things, and NICE kind of talks about clonidine and things like that. For hot flushes, there are lots of things that can help, but really, most of the time, what you need is the estrogen replacing. So HRT, generally leaves them standing. But if you've got patients that really can't have HRT, for example, I've got a patient who's got active breast cancer that is hormone fed, there is no way she can have HRT. And then clonidine, gabapentin, SSRIs, and the things that come in for anxiety and for the hot flushes are brilliant. And talking, NICE talks about CBT, but I think we need to go really further with that. But as I keep saying, I don't think that these are alternatives. It's a package, and you can't have one without the other. So tailoring that lifestyle advice to the person, signposting them to things that can help. CBT is great. Psychosexual counselling is great. Unfortunately, in Shropshire, we don't have much of a commissioned psychosexual service, but there is still some psychosexual counselling that you can do, or that your gynae teams can do. Talking about mindfulness and gratitude journaling, getting out in nature, really explore their symptoms and their expectations. Now, I would say I'm always kind of slightly conscious that I come from this as quite a privileged position, that I have the time and the flexibility with work to be able to think, oh, well, actually, I'm not feeling great today, so I'm going to go take my dog for an hour walk and I'll catch up on work a little bit later. You can't do that if you work in a factory. Gratitude journaling is something that's quite that I think is very powerful. Is something that I think we underestimate, and I used to roll my eyes really when people said gratitude journaling, but I think it's one of the next big things really with menopause, because it gives you context. It's like a reflection journal. I'm sure all of you clinicians have done reflection journals, especially when you're doing courses and things. Reflection journals are fantastic because it gives you context. It gives you a step away from things and lets you add some context and learning to situations, doesn't it? And gratitude journaling just does the same. And there's something very mindful about writing things down, isn't there? And I'm a big fan of my my journals and my little notebooks. I have different coloured notebooks for all sorts of things, because writing something down just seems to help. But gratitude journaling is fantastic. It doesn't have to be for big things. You don't have to have something massive every day. Mine will vary from, I'm thankful for a big holiday that we're planning or something exciting that we're planning, down to the other day I had a fantastic day that I text my friends about, Jodie being one of them, because I'd started my day off. My hair had gone into a lovely ponytail without any effort and I looked very cute. I was very pleased with that. I'd got a free lunch because I'd bought it the day before, but hadn't. I'd bought too much basically from M&S. So today I'd seen that day I'd got a free M&S lunch that I hadn't had to think about. So, it can be just little shallow, stupid things, but it gives you some context and it gives you some grounding. But you do have to be careful how you talk to patients about things like this, because as I say, a lot of the time we are coming from a little bit more of a privileged position than a lot of our patients. So it can be difficult. So onto the MSK side of things, really. I don't think I need to talk to you about osteoporosis, especially, but we'll talk about it a little bit. But just a bit of a reminder, really, about the muscle loss, about the tendinopathies, and about the pain prevalence side of things. So, osteoporosis. Nice days, we should be giving advice about bone health and osteoporosis at the first appointment, and again when you're reviewing that treatment. So, from a menopause point of view, HRT isn't the most common treatment, obviously, for osteoporosis, but for perimenopausal and postmenopausal women within 10 years of menopause, it is a good choice. And it can be something if they're not tolerating it, other treatments, for example, or they've got, you want to look at the other cardiovascular health benefits and the symptom relief it can offer. It can be a fantastic first choice. We need to think about contraception in the perimenopause. There are contraceptions like the depot injection can potentially reduce your bone mineral density. So if they're in that perimenopause and they've been on the depot for 30 years, then often that early HRT again is really important. But we do also need to think about the other aspects. You need calcium, your green leafy veg, vitamin D. I mean, I really go on about vitamin D to pretty much all of my patients, whether they're menopause or not, because in this country, most of our vitamin D is low over the winter, especially. And for a simple supplement, it's a really good lifestyle adjunct to take. But also talking about what type of exercise, talking about weight bearing and impact through your joints. I'm sure I don't need to tell you guys about this at all. I'm sure you could do this slide much better than me. But I think, and I'm guilty of this, my exercise is running because I like running and I'm really rubbish at resistance exercise. But actually, as you get older, that that weight and the resistance stuff is really important. And starting HRT early enough. You know, you don't need to start it in your 30s. You don't need to start it in anticipation of menopause, but starting it within 10 years of menopause, really getting all those benefits and not just the risks. And muscle, I'm sure the rocks muscle is all natural. But you can lose muscle strength as you hit menopause. And again, HRT can help with that. But as does carrying on with those daily exercises and the your kind of daily activities. Bone kind of adapts its mass and architecture and strength to changes in stress and muscle activity. So your reduced muscle mass will affect your bone side of things as well. And again, I'm sure I don't need to tell you this, but it's something we kind of forget in general practice, that we talk maybe quite a bit about osteoporosis, but we forget the effects of that muscle mass on that as well. And the tendinopathies. So these, I think, are really important, and I think something we massively forget about. So during menopause, your estrogen, and again, I'm sure I don't need to tell you all of this, but your estrogen controls your collagen metabolism that helps maintain that strength and flexibility. So when your estrogen levels are dropping or being all over the place, your collagen production decreases, and then they break down much more easier. Those fibers break down easier. And so you end up with stiffer joints that don't really respond to the muscle demands, and that you'll just injure them easier. And gluteal tendinopathy and Achilles are the two that really in menopause come into their own, unfortunately, and are quite difficult ones to get on top of, and can be quite limiting. So it is an important thing to think about. And again, you know, maybe it's not the only reason we take HRT, but it might be something that tips that balance for patients if you can explain those, as I say, explaining those benefits really. And lastly, I just really wanted to mention about fibromyalgia. Now, I'm not saying that all fibromyalgia is perimenopause or menopause, and vice versa, but there is quite an overlap of symptoms and of age of diagnosis, and that fluctuated and low hormone levels increase your pain. So thinking about it, if you've got someone with perimenopause that you can't get on top of, is there some fibromyalgia there? If you've got someone with fibroflare that you can't get on top of, actually, will HRT help with that? Are we talking a little bit about some perimenopause symptoms in there as well? Because an awful lot of those symptoms are very similar, aren't they? There's quite a lot. Postmenopausal women are more likely to experience pain related to fibromyalgia, and giving back some estrogen, it's thought to reduce their pain by about 50%, because you're just getting steady estrogen levels instead of being all up and down. So estrogen and progesterone and testosterone have massive parts to play in chronic pain pathways. And if we're steadying those and changing that cyclical pattern in perimenopause, it might really help. We do also need to think a little bit about trans patients, that transgender men, the in utero exposure to female hormones in transgender men, they have a higher risk of fibromyalgia than trans women, despite the hormone replacement side of things. So again, it's something to think about with our trans patients. And I just quite like, this is one that I often show to patients as well, that there are times where your pain intensity and your pain sensitivity will fluctuate with your hormones, and acknowledging that fluctuation, that there might be times of the month where you need more painkillers maybe, or where you need to be a little bit more conscious of your exercise regime, or you need to change things around a little bit. And of course, much like I've talked about lots with HRT, with fibromyalgia, we're encouraging with CBT, with exercise, lifestyle changes, self-care, gratitude journaling, those exercise programs, all of these things that again have that overlap with a lot of menopause side of things. And HRT, if you've got someone of the right kind of menopause age that is having really bad flares of the fibromyalgia, even if they're not having other menopause symptoms, it might be worth talking to them about HRT anyway. And I'm kind of coming up towards the end, so hopefully we've got some time for some questions as well, if anyone's got any questions. But basically, menopause can be rubbish, but you need to think about education for your patients and for for you. You also need to think about it in terms of not just your patients. There will be women in your life. You know, in nursing, we work in a predominantly female profession, but there will be women in your life that are going through menopause that actually you being aware of it can help with. HRT and thinking outside of the risks to the benefits as well. Exercise and what type of exercise we're recommending. CBT and kind of psychosexual side of things, and the lifestyle that it as a package and not alternatives. And I normally always put, you know, the standard slide of references, and I can put lots of journal articles and lots of references and nice guidelines, but you can all find that, and you're all very accomplished, I'm sure, at finding those kind of things. But these are ones that I think are more helpful. So the BMS obviously is fantastic from a menopause point of view. The primary care women's health is the one where that other infogram came from that's really good. The Faculty of Sexual and Reproduction Health have lots on, and the Royal College of GP. And then at the bottom here, Balanced Menopause. This is Louise Newson's site. I always say to patients, I signpost a lot of patients to the site. They've got a great app, great site. I always say, don't pay the money and book an appointment. But, you know, and there's obviously the panorama aspect of it now. But the website is brilliant. It's got lots of useful information on there. And the Flow app is really good as well for looking at symptoms and diarising symptoms, journaling a little bit. And then these two, we haven't really talked about menopausal vaginas, but menopausal vaginas are the bane of a lot of women's life, and having that vaginal atrophy and vaginal dryness, and the changes to their libido and sex life and urogenital health just because of that. And these are two fantastic books. Me and My Menopausal Vagina and Love Worth Making is more about the psychosexual side of things, and they are great books to read yourselves, but also to signpost your patients to. And let me see if I can just stop sharing and come back.
Well, thank you very much, Patsy. That was fantastic. I think it's just it just really reinforces the, you know, empowering the patients and bringing in the whole like psychosocial aspect, isn't it? And it isn't just about a prescription. It's about making sure that we're addressing all the other things within the patient's lives as well, and other factors that might be contributing to the symptoms as well. Thank you very much. That was very, very interesting. We've got a couple of questions, if that's all right with you, Patsy.
Yeah.
And okay,
Yeah, I'll just do. Okay. So between RA and chronic fatigue syndrome,
yeah.
So it's all about the hormone fluctuations. So it is, I mean, I can kind of go into that quite a lot, but it is just all about that fluctuations. If you remember that graph where it's all over the place, and that estrogen going up and down is what tends to is what gives you a predisposition, and your risk of RA goes up, and chronic fatigue, yeah, much the same.
Really interesting. Can you see the question off, Lucy, or would you like me to read it out? I don't mind.
Oh, do you think that menopause-related pains improve once they're through? Yeah, I think quite often they do. It is a little bit of a, so women often ask me how long menopause will last, and it's a bit of a like, well, for most women, I can tell you what the averages are, but actually I've got women in their 80s that still have really strong menopause symptoms that are still on HRT, and anytime they pause that HRT, life deteriorates kind of thing. So, but for most women, once you get into that steady, it's the fluctuating and that up and down bit. Once you get into a steady range and you're kind of in your 60s, for most women it settles down, and that's when most women naturally come off HRT after about 5 to 8 years. So yeah, I mean, I always kind of reassure them that their menopause symptoms hopefully will improve, and that as they get into that steadying of, and that lack of up and down of hormones, hopefully it will improve. But there are some women for which it doesn't. And we used to talk with HRT about the smallest dose for the shortest amount of time. And we don't so much now, because we've got these safer ones that actually you can be on till if you're in your 80s, if you need to be. It is all about listening to their symptoms and going from there.
Yeah,
Oh,
fantastic.
thank you, Lucy.
And I've got another, well, a statement really, isn't it, of Louise, which totally agree with. Urogenital symptoms are often overlooked, aren't they? Within
Yeah, massively. And I think
yeah,
part of that
pregnancy.
is, yeah, and we're very English, aren't we? We don't really like talking about
Wonderful.
vaginas. But actually, when I talk about I've had a lot of people now because of Davina. Davina's fantastic.
Hmm.
I think, I've got some conflicting ideas, like with Louise Newson, of what they say sometimes, but just raising that awareness. But lots of women come to me now for testosterone. But actually, in women, sex is a lot more complicated. And one of the things that we massively overlook is that if you want good sex as you get older, you might need a nice, moist, happy, sexy vagina. And if we're neglecting that bit, then you can give all the testosterone and you can boost all that, you can do all the psychosexual stuff. But if it hurts when you have sex, it's not worth it. So actually getting that estrogen replacement, like Vagifem, or there's lots of different estrogen ones now that you can use. So some people struggle with the Vagifem and things, but there are some different ones, and using a good, not just HRT, again, using the HRT so use topical vaginal estrogen in combination with vaginal moisturizers and lubricants, but the right ones, not Durex Play. They're terrible. But yes, and some of the right ones. And if you have patients, if you come across this a lot, or if you're interested in this, that those two books are fantastic, and that My Menopausal Vaginal is a good read.
Yeah, really, really good. And then there's a question by Alison just saying, do vaginal pessaries give HRT benefit other than vaginal dryness? Other than vaginal
No,
dryness, yeah.
generally not. So we have vaginal pessaries like Vagifem that are the higher dose ones, and then we have the lower dose creams, and then we have the ultra low dose oil-based cream Blissel now as well. And they do tend to just act where they need it. They don't tend to give any systemic effects. Now, I do have a couple of patients that are very sensitive to it, and I've got one patient that swears her Vagifem has cured her hot flushes and everything. I think some of that is the placebo side of things. She's very sensitive to paracetamol. She only takes half paracetamol. So some people are just very sensitive to things, aren't they? And if it works, it works. But
Well,
no,
yeah.
but they have none of those risks at all. I mean, you do have to be careful because the MRHA things in them are still for oral estrogen. So you do have to reassure patients that those risks are not there with Vagifem. And you do have to taught them how to use it, because they are quite I'm looking around my desk because I've got a model vagina over there, and I've generally got pessaries and things on. I've got ring pessaries, but I haven't got any of the Vagifem ones. But they're like a thin applicator with a tiny tablet. So you do have to talk them through how they're using it and what they're doing.
Yeah. Fantastic. And Hugh's just mentioned, to be clear, did you say progesterones are more breast carcinogenic than estrogens?
So it depends. So we know that there is no increased risk, or little to no increased risk, with transdermal estrogens. And with micronized progesterone, we know is breast neutral for 5 to 10 years. But the synthetic progesterones do all have a slight increased risk of breast cancers. But they are only the same kind of increased risk that you have with the combined pill and kind of contraceptive hormones as well. So you do have to put it into context. But there are options now. If you go for transdermal estrogen with a micronized progesterone, that combination has little to no increased risk in breast cancer. And age actually is one of the biggest risks, and fatness, unfortunately, for me.